Hello and good morning. My name is Angela Forshaw-Rouse, and I'm the manager for community outreach and operations here at AARP Pennsylvania. And we're so thankful that you had the opportunity to join us this morning as we gather together to talk more about disparities, specifically in Pennsylvania. We are here today to talk about a new report that AARP worked with our Drexel University team entitled Disrupting Disparities in Pennsylvania. Joining us today again are researchers from the Drexel University College of Nursing and Health Professionals, along with national and statewide stakeholders to highlight how geographic, racial, and economic factors restrict access to healthcare services for many Pennsylvanians, creating disparities that have become more pronounced during the COVID-19 pandemic. Disparities in the US inhibit longer, healthier, and more productive lives. At this time, to talk more about disparities across the country, I'd like to call upon Dr. Jean Axius, Senior Vice President of Global Thought Leadership with AARP, to speak on how AARP is addressing the impact of disparities among the 50-plus population. Dr. Axius.
Good morning, Angela, and thank you, and good morning, everyone. As Angela said in her opening remarks, disparities inhibits people's ability to live longer, healthier, more productive lives. And for more than 60 years, AARP has been on the front lines working with our partners and working in communities and states to really ensure that everyone has an opportunity to be empowered and to also choose how they want to live as they age. At AARP, as we look to the future beyond COVID-19, one of the areas for us is to build equity in the recovery in terms of health, wealth, and aging. And as our CEO, Joanne Jenkins, has said in the past and continues to say, is that we see this as an opportunity to build our efforts to address longstanding disparities in health and economic security and quality of life, and to redouble our efforts to combat racism and ageism. All people should have access to the resources, services, and support that they need in order to live a life of dignity, good health, and purpose, regardless of age, race, or income. As Angela indicated, I am extremely pleased to serve as the strategy lead for AARP as we not just redouble our efforts around closing the disparities gap, but really looking at the opportunities to think about ways in which we can co-create solutions with our partners across the country, with our colleagues in the states, with our community leaders, to really ensure that people have an opportunity to live that longer, healthier, and more productive life. There's a couple of principles that is really driving the work that we're doing at AARP that I just quickly want to mention. The first one is that we all have a responsibility, a personal, public, and private sector responsibility to advance the issues of equity. This is not just a challenge in terms of the need to close these gaps, but this is also an opportunity to think about not just the moral imperative, but also the economic implications of not closing these gaps. What's the cost of doing nothing? And it's clear to all of us that after the last 14, 15 months with COVID, with the implications of COVID, with the disproportionate impact of those who've been impacted by COVID, that we really have an opportunity to build our systems in a way that's more equitable. And that also serves all of us collectively. In other words, disparities, not only does it inhibit people's ability to live longer and healthier and productive lives, it also stifles economic growth. The other strategy and principle is that this really is around solutions, and you're going to hear many of those solutions today, and that these solutions have to be created with communities, with those who are most impacted, those who are in the front lines, because those who are closest to some of these challenges are the ones that are best positioned to really help solve them. And then finally, as I indicated before, this really builds on AARP's long history of working across the country and with our partners to close the opportunity gap so that all can have an opportunity to live that longer, healthier, more productive life. Congratulations to our wonderful colleagues in Pennsylvania and our partners. It's an amazing report, and I'm going to turn it back to you, Angela.
Thank you so much, Dr. Axius, for your wonderful comments. You struck me with what is the cost of doing nothing. That's so important for us to kind of remember that as we talk through some of the implications and move forward with some action steps that our community partners, elected officials, and policymakers can actually take steps to change. If you are a member of the press joining us today, we thank you. And we want to remind you that if you do have a question, that you identify yourself and you place your question in the Q&A feature on the bottom tab. Thank you so much for your time today. As we studied how Pennsylvania can begin to retool for geographic, racial, and ethnic growth, our research really indicated health inequities are most acute among those living in rural populations and low-resourced areas of the state, among underrepresented populations. And those that were identified as being severely underrepresented, according to data, were particularly within the African-American Black populations and our Latinx populations across the state. Of those who lack access to healthcare, experience the digital divide, and face persistent local healthcare workforce shortages. And we will be able to examine those areas quite a bit during the time that we have today. Joining us now from our research team at Drexel University's College of Nursing and Health Professions are Dr. Roseanne Ghalili. She is a professor of nursing and associate dean for Drexel University, and Dr. Laura Gitlin. And we're so happy to have the both of them be here too. Dr. Gitlin also serves as dean. So we are very excited to have them take us through a little bit more of the highlights of our research.
Well, thank you, Angela. And thank you for the warm welcome. We at Drexel are really honored to partner with AARP on the first report on disrupting disparities in Pennsylvania for people 50 years of age and older. When we sat down with AARP to lay out the framework for the report, we decided this first Disrupting Disparities report would be a primer on understanding really the key geographic and racial and ethnic disparities in the state, upon which to generate actionable solutions and pave the way for future work in this critically important area. Our research approach included conducting a comprehensive literature review, an analysis of the databases at the state and federal level on the health of Pennsylvanians, and interviews with key stakeholders, many of whom you will hear from later. Now, as we know, Pennsylvania is the 5th most populous state in the country, and we rank 8th in the nation in terms of the percent of population over the age of 65. Of the 67 counties in Pennsylvania, 72% are rural and 28% are urban. Now, many of you are probably wondering where in Pennsylvania are health inequities most acute. The answer is simple, both in rural and urban areas. We'll go into specifics during this briefing, but today most older Pennsylvanians live in rural areas and are primarily white and low income and reside in areas with a high dependency index. Older adults living in these rural areas live with geographic challenges in terms of access to healthcare, access to transportation, and poverty. The more populated urban areas of the state include low-resourced areas and underrepresented multicultural communities, and we'll hear shortly about the growth that we will see in this area, all of whom also lack access to healthcare and culturally appropriate evidence-based health promotion and chronic disease management practices. So we have a lot of work to do together, and to turn now to Laura, who will dive a little bit deeper into the issues around health inequities in the state and the impact on healthcare providers.
Great, thank you. Roseanne, and I just want to echo Roseanne's gratitude to AARP. This has definitely been a partnership, and it's been a very exciting, in-depth exploration about Pennsylvania. And this report reveals a very critical story about Pennsylvania. And in a way, Pennsylvania looks like the rest of the nation. The state is rapidly aging, and some people don't realize that this will continue. The state will continue to age just like the nation. And as a nation, we're a super aging society, and Pennsylvania is right in there. So while this is good news, and in that people are living longer, as everyone has stated, not everyone is aging well or able to live as long as others. And the critical take-home message from this report is that it shows where an older adult lives, their age bracket, and their racial and ethnic group are all critical in terms of determining how they're going to age, their prevalence rates for chronic conditions, their experience of social isolation, their exposures to structural and social determinants of health, including housing cost burden, poverty, food insecurity, access to the internet, and you'll hear more about that shortly, and their level of computer and health literacy. In terms of geographic inequities, currently, rural residents who are primarily white are older than their urban counterparts, and their poverty rates are higher, and their access to healthcare and hospitals is quite problematic. There are counties that have very few hospital beds or hospitals available to our rural older adults. The other part of the story, however, that's very important to understand is that in a very short years, about 20 years, by 2040, urban counties in the southeastern portion of the state will have the greatest increase in the number of older adults. And in urban areas, it is our Black and Hispanic and some Asian older adults who are aging, but they're aging with lower incomes than whites, higher rates of cognitive impairments and disabilities, a higher number live below poverty, and they're more likely to live in unaffordable housing. So they're aging in housing stock that doesn't fit their needs. And they have less income for food and healthcare. So with age, inequities continue and they increase in different ways. There are also, the report reveals, inequities in terms of age itself. For example, people who are late middle age, 50 to 64, are more savvy technologically. They use technology more compared to the oldest old that are living in both our urban and rural areas. Of critical importance in all of this is that older adults do not typically have access to healthcare for their needs, which are primarily chronic disease management and prevention. So with an aging society comes the need to really change our healthcare paradigm, and also the need to expand and diversify the healthcare workforce. And this report documents that very well. New competencies are needed for a culturally diverse group of older adults, different kinds of cultural competence, and knowledge of evidence-based care for prevention and chronic disease management is severely lacking. So this report provides evidence of the shortages of healthcare providers who are competently trained for older adults who are quite diverse racially, ethnically, and geographically. For example, in 2013, there were 205,000 licensed RNs in Pennsylvania, with only 20% working in rural counties, and very few were non-white. Also, there's a lack of race and ethnic diversity of the healthcare workforce for other healthcare professionals throughout Pennsylvania. So that's a little bit of a snapshot. And what I'd like to do now is ask Dr. David Saunders, Director of the Office of Health Equity in the Pennsylvania Department of Health, to share some very important insights that he shared in the course of developing this report on disparities in rural and urban areas, as well as the increasing role of telehealth in addressing healthcare needs of older adults. I'm going to turn it over to you, David.
Thank you very much. Appreciate that introduction. It's clear based upon what Laura just mentioned, all that's in the report, that there are disparities throughout the state, not just in urban Pennsylvania, but also in rural Pennsylvania. We are all in the same storm of COVID-19, dealing with the pandemic as a collective, but we're clearly not all in the same boat. Due to the fact that many communities lack investment, lack resources to live a quality life, you see a stark difference in life expectancy. In some cases, you can see a 20-year difference, just miles away from various communities. These differences tend to run along race and ethnic lines. Income is a prevailing factor. Addressing these underlying structural impediments to healthy lives is something our office, the Office of Health Equity, is keenly aware of and trying to address. When we lose our older adults at a young age, we strip families from loved ones who are older and wiser. Our older Pennsylvanians provide care to grandchildren. They are trusted advisors to many. So when we lose them, we lose a huge part of our community. There is great information in the report that speaks to social isolation. As mentioned in the report, this presents mental health challenges when we are physically distanced from our loved ones. And while we're slowly but surely coming out of that, we hope with the increase in vaccination, it is an issue I think that we're going to need to address and combat going further out. Perhaps one way to do that, which was also delineated in the report, is what we would call a no wrong door approach, making it easier for people to find the supports and the connections they need is one way to reduce social isolation and really reconnect our communities to each other. So a no wrong door approach is something that I hope to see us as a collective, through our different state agencies and nonprofit organizations, really look at. From a telehealth perspective, I know what will be discussed later on in this session is really addressing the digital divide, working with communities to train those communities that may have lower health literacy on how do you access digital health platforms, of course, providing the hardware and the connectivity to those devices, but really to increase the opportunities for individuals to have care is something that the Office of Health Equity, the Pennsylvania Department of Health as a whole is quite interested in. So with that, I will turn it back over to you, Laura. Thank you very much.
Great, thank you so much, David. And you raised so many very critical points. And one I would just like to emphasize is how life expectancy differs geographically. And we can even map out differences in the number of years that people on average have by zip code and due to structural and social determinants. And I also appreciate that you raised the consequences of aging, and we'll get into this in a moment, in terms of having limited access to technology. It's not only the physical consequences, the health consequences, but it's also social isolation. And there is ample research on the role of social isolation in terms of its negative consequences on psychological well-being, but also it's a predictor of mortality. So this is very serious, very, very serious. And this is definitely something that the report reveals. And it is related in part, not totally, but in large part to the role of the internet in people's lives. I mean, obviously, look where we are, right? We're very dependent on the internet. I'm sure many of you use the internet to sign up for your COVID vaccine. But the report is very clear about this in terms of what's going on in the state of Pennsylvania, and that is internet access is not available equitably across the state. And this referred to as the digital divide is furthering inequities. It's putting lots of people at a disadvantage. And again, clearly we see that for COVID, although it's been there before COVID, and it affects everything from being able to have a telehealth visit with your physician or your nurse practitioner to accessing very basic information about healthcare. So for those without access to broadband internet, and they don't have access to telehealth care. And this was compounded by COVID because many of the community agencies, senior centers, adult day services, libraries that have had to close because of COVID are the places that older adults turn to use computers if they do not have broadband in their home. Now, when we talk about the digital divide, the infrastructure for broadband that David referred to is quite critical. And we also have to talk about computer literacy. And a way to think about computer literacy is not just how do older adults have to learn how to use different kinds of technologies and become savvy in internet use. It's also what is the computer literacy of our healthcare providers and our healthcare organizations in how they message and how they reach out to different communities. So we have to think about computer literacy both from the individual perspective as well as the organizational perspective. One of the stark findings of this report is that few counties in Pennsylvania are able to support 100% of their residents to connect to the internet. So not all older adults could even join us today. Some 7% of Pennsylvanians who are 50 years or older report difficulty understanding information from a healthcare professional, and then they can't use the internet to get more information. Although as people age, there's an increasing number of savvy technology users among people 65 and older. For the most part, people 65 and older are less likely to use electronic devices to look for health information, to look up their test results, to go on their healthcare providers' confidential websites, to track their health changes and so forth. And older residents overall in both the rural and in some of our urban areas are disproportionately impacted by this digital divide. Again, due to the lack of access to broadband, to internet, to smart devices, as well as their digital literacy. So this is definitely has to be a priority of the state. It's very significant. And as we've learned from COVID, telemedicine, telehealth approaches work, and they should be continued. They should be expanded. And I know that people are working on this in the state and also nationally in terms of looking at reimbursement. And we also have to look at it in terms of how do we prepare a workforce to use the best evidence and best practices to engage in telehealth at the same time that we have to expand the infrastructure for broadband use and our health literacy. So I'd like to now turn it over to Jeffrey Roach, who's the Executive Director of Strategic Healthcare Initiatives and Partnerships of Harrisburg University of Science and Technology. And he was one of our key stakeholders who shared really important insights in our report about high-speed internet and also social determinants of health. So I'm going to turn it over to you, Jeffrey, for some of your thoughts on this.
Thank you, Dr. Gitlin, and thank you all for being here with us on such an important topic. I'd like to just begin by thanking my amazing colleagues at AARP and Drexel University for this research, because as you've heard from all the other stakeholders, we have to highlight specifically how the geographic, racial, ethnic, and economic factors are combining, or as we should say, have combined to restrict access to healthcare services for many Pennsylvanians. You know, as I approached, this opportunity, I thought about it through the lens of serving as one of the leaders through our health equity response team under the leadership of David Saunders where we specifically looked at the impact to our older Pennsylvanians. And it was clear, even before the pandemic, but specifically during the pandemic, Pennsylvania has a lot of work to do to ensure that everyone has a fair and just opportunity to be as healthy as possible. We have to look at this from the vantage point of what can we all do? And that means everyone, policymakers, community leaders, organizations, individuals. We have an obligation and a responsibility to specifically look at what we can do to remove all obstacles to health. And as we heard today, that includes a lot. We've heard of poverty, we've heard of discrimination, powerlessness, lack of access to good jobs. But today we've also heard about quality education, housing, transportation, access to quality technology, and a whole lot more. As we think of the social drivers of health, as we've talked quite a bit about today, it's clear that, as many other thought leaders have so eloquently stated before us, the political determinants of health create the social drivers that affect all other dynamics of health. When we unpack this further, we can specifically see how federal, state, and local government levels, specifically the actions that our government takes, can lead to social conditions that can cause inequities or even just further build systemic barriers. This is what we see with the infrastructure. This is what we see with the digital divide. And I would say today that this report by AARP and Drexel University has abundantly clearly said that Pennsylvania needs an all-government approach at all levels, in addition to a genuine public-private partnership that specifically looks at what we need to do to not only address the access to broadband internet, address the access to the health literacy issues that all communities in Pennsylvania face, but specifically for our older Pennsylvanians. This digital divide, as we've studied so closely, we know has not only just led to poor health outcomes, but it's also led to less access to quality care, and unfortunately caused more health inequities. Take, for instance, during the pandemic, we heard earlier today from our other stakeholders and panelists that we know our healthcare systems and providers did their very best to pivot quickly to telemedicine. Yet at the same time, many Pennsylvanians throughout rural, suburban, and urban communities did not have access to the right technology. They may have been told, use your iPhone, use your smartphone. Maybe that was the first time they've ever used their smartphone or their iPhone to even envision receiving healthcare. And we have to remember that it's to receive equitable and essential care. We've heard the stories of our Pennsylvanians who have actually now faced more severe health issues simply because of the impact of the digital divide, simply because of where they lived in Pennsylvania, and because they may have been on a Zoom, on a Teams, or on their mobile phone, and it stopped while they were receiving care. That has implications, as we've heard others talk about, not just to that individual, but also to our entire healthcare system, the costs that all of us face, but more importantly, the future of our Commonwealth. As we look at this further, it proves that it's all of our responsibility. As we travel across our Commonwealth and look at rural, urban, and suburban communities, we can clearly see that we've got to look at this issue of broadband internet, access to technology, and equitable access to care from the vantage point of what can we all do to ensure that every Pennsylvanian has a fair and just opportunity to be as healthy as possible. It also means that we have to meet patients where their needs are at. We have to bring care to them, whether it's through technology, but we have to ensure it's care that meets them where they're at. And so in closing, I just want to again thank AARP Pennsylvania and Drexel University. And it is my sincere hope that our governor, our General Assembly, and all of our leaders at all levels of government will hear us loud and clear today in the most generous and compassionate way, that it is beyond time that we take steps immediately to ensure a healthy Pennsylvania for all. At this time, I'd like to hand it over to our next speaker, which I believe is Roseanne.
Great. Well, thank you, Jeffrey, for that wonderful discussion and passionate discussion about the needs of telehealth and broadband access. And I really want to turn our attention right now to really looking at where are the medically underserved communities in Pennsylvania. We alluded to this a little bit about access to care via COVID through telehealth, but I think it deserves a little bit more attention because, again, this is a hidden story in the state that really deserves attention. I first want to really define for everyone, because we have a broad audience, about define what is a health profession shortage area and a medically underserved area. Now, these are designations by the government. A health profession shortage area is a geographic area, population, or facility with a shortage of primary care, dental, or mental health providers and services. And they use 3 criteria to designate this. This is population to provider ratio, percentage of the population below 100% of the federal poverty level, and travel time to the nearest source of care. A medically underserved area or population are based, again, on provider per 1,000 population ratio, percentage of the population at the federal poverty level, but also the percentage of population age 65 and older and infant mortality. Now, if you think about Pennsylvania, we know that we will not have an adequately trained workforce to provide care for older adults in Pennsylvania. But we also know that 14% of Pennsylvanians live in a medically underserved area, and 22% live in an area that are both medically underserved and designated as a health profession shortage area. So this has significant implications in terms of access. Residents of these areas live in rural areas or are of minority status, poorly educated, and live in poverty and have limited access to transportation. Now, if you look at the maps that we have in the report, you'll see that there's pockets of these health profession shortage areas and medically underserved areas throughout the state, primarily in rural areas, but there are also in urban areas as well. So ensuring equitable access to care and using telehealth technology can go a long way for both those individuals that live in these rural and urban areas. Now, I'm going to turn attention for a minute to pharmacy deserts. And I noticed in the Q&A, someone asked about what was the most surprising part of putting this report together. Well, this to us was the most surprising part. Jana Hirsch, who's not on the call, our colleague in the School of Public Health, put this great publication out, and I asked her to do a deeper dive and develop the maps just for Pennsylvania about changes in pharmacies over a 10-year period, as well as ambulatory care. And we were shocked by this. And this was early on in the report when we were developing this, when we didn't even know that the vaccines were approved yet. Our data shows that there are pharmacy deserts across the state in both rural and urban areas. And each of the 67 counties in Pennsylvania have at least one pharmacy desert. Now, what exactly is a pharmacy desert? I know that's what you're going to ask. In the urban areas, a pharmacy desert is a low-income community or neighborhood with no pharmacy within a half a mile for those with limited vehicle access. Also, for those low-income communities with adequate vehicle access, the defining radius extends to a mile. On the other hand, a rural pharmacy desert is an area within a 10-mile radius without ready access to a pharmacy for those that have access to transportation. And we know in rural areas, we don't have mass transportation. Now, this is really important when we think about COVID-19 and the rollout of the vaccines. While there's still some mass vaccination sites around the state, we do know that these are going to close shortly. So individuals will need to obtain their vaccines at their local pharmacy. But the question that we need to ask is, how will people have access to these in these areas that we know we have pharmacy deserts in both the urban and rural areas? And this is really an issue that we all need to address together. So with that, I really want to take the time now to turn the mic over to Dr. Nancy Mim from Harrisburg University. She's also one of our stakeholders in the report who will further elaborate on population health and health disparities.
Good morning. Thank you so much for that introduction. I would really first like to thank Drexel University and AARP for this critical work, critical insight that we are providing. You provided with this research. And I wanted to share with you a couple points. No one should ever have to make the choice between their medications or food. COVID didn't cause this. That's not what I'm suggesting, but it has brought it to light and opened people's minds to try to understand the long-stemmed issues we have related to health equity and access to care. And moving forward, we need to be creative and come up with unique ways to reach and meet people where they are so that they have equitable access to health outcomes. And we are serving each Pennsylvanian equally so that they can all have the best opportunity to have good health outcomes. And I am just so proud of this work. And with that, again, thank you for everybody that's participated and taking the time to open your mind to embrace this. And I'll turn this back over to Angela.
Thank you, Nancy, for those really important points. I mean, our team at Drexel and our wonderful stakeholders have given us a lot of thought, much of which we know, but it's so important to gather together to talk about where we go from here as we begin to look past and many of us are still in the COVID-19 pandemic. Again, I'd like to remind all of our reporters that have joined us today, if you do have a question, please identify yourself in the Q&A portion and place your question there. Right now, we want to turn our attention to some of the actionable recommendations that we've made in the report. There are many opportunities that we can take as nonprofits, for-profits, elected officials, governmental agencies in terms of what we can do as a collaborative to move forward and really address these disparities that we've discussed today. So I'm going to ask that my Drexel team join me, but I wanted to take light for 2 points, if you will, on our recommendations. The first recommendation that our research pointed toward was that we should continuously monitor health, geography, and racial and ethnic disparities. The report has over 108 reference points. You can imagine how much data our research team piled through just to make sure that we could get accurate information from Pennsylvania. There's a need for us to assure that we have a continuation of monitoring for our public health, definitely within counties to which identify specific needs of care. And we want to make sure that we have adequate prevention programs and disease management of chronic conditions, which there was a very interesting section in the report to talk about the prevention for some of our chronic conditions, primarily in some of our African-American and Hispanic Latino populations, and some numbers that point towards that. I feel that's a very important data point that we should definitely follow. The second point that I would share in terms of recommendations is providing broadband access across the state with technology and literacy and expanded telehealth, which we definitely just addressed now in terms of the importance of telehealth. But digital literacy is so very important, not only access to high-speed internet connectivity, but also technology and the literacy to use the technology. We see that as definitely an opportunity to do better in the state of Pennsylvania. We know, again, that our internet access is not available equitably across the state, and that is something that we can change as a collaborative here in Pennsylvania. We need to make attention to our broadband infrastructure, and I know that there are many conversations happening right now in our General Assembly, as well as AARP, to continue that conversation to make sure that there is equitable access to broadband in Pennsylvania. And now I'll turn it over to our Drexel team for follow-up for a few of the other recommendations.
So I'll start, thank you, Angela, with our third recommendation. I don't think it'll be a surprise because we basically have said this, that we have to prepare a healthcare workforce who's very skilled in telehealth and who can provide culturally competent care in prevention and chronic disease management, which are really the main healthcare issues for older adults. Now, when you look at all these recommendations, they really, in many ways, are interrelated, and it's going to take nothing short of a multi-pronged approach as Jeffrey mentioned, public, private partnerships, government, universities, and so forth. So it's not just going to be one approach, they're all related. As it concerns developing a healthcare workforce, we know from many national reports that there will continue to be a shortage of health professionals in every discipline who specialize in geriatric care. And this is something that we're going to have to really problem solve. It's not possible, and these are national reports that have concluded this, that we will be able to train all the health professionals we need in geriatrics. But certainly geriatric content has to be infused in the curriculum right now for everyone and everywhere. There are certainly numerous other strategies that we illuminate in this report, such as for this recommendation, such as creating a statewide workforce database of licensed health professionals, provide formal training to health professionals in best practices, as I said before, for delivering telehealth care. What I just said as well, infusing geriatric training in some level, really taking a life course perspective and strongly understanding the social and structural determinants of health. Other important recommendations that we need to talk about in terms of, or strategies, I should say, for this recommendation is what would a loan forgiveness program look like? What would different kinds of programs look like to bring different health professionals in rural areas? Now, I just want to take a moment because I did see a question about what do we mean by cultural competent care? And while there are various formal definitions, I would say that a general understanding of cultural competent care is that health professionals are schooled to acknowledge the values, the preferences, the personal goals, and how to assess them in older adults, and also how to overcome mistrust from particularly our Black and Latino communities who have historically confronted very negative interactions being experimented on, actually to this day in many different ways, who remain mistrustful, and actually that's an adaptive, I think, approach. And so it's on the healthcare professionals to really work hard to address mistrust. But in terms of competence, that's what we mean. How do you elicit the values and goals and preferences of individuals? How do you use the language or the preferred words and ways of understanding diseases in order to move people along and educate them in terms of what they need to do? And the other piece to competent care is introducing in our education an understanding, a strong understanding, not only understanding, but how to act on structural and social determinants of health. So when you're meeting with a person in a clinical setting, what does their zip code tell you? And how are you going to understand that? How are you going to understand and act on and discuss and consider the role of racism, which we know racism and exposures to different kinds of discriminatory practices throughout the life leads to mortality and a risk for death. So this is a very critical third recommendation that we have. I think you can see it naturally flows from the data that was collected. And then I'll also just very briefly mention our fourth recommendation, which is overlook that we as a nation and in the state overlook the backbone of our long-term care system for older adults, which really are family caregivers and also direct care workers who exist in all care settings. So support for this group in particular, we shine a light on this group as there is various legislation right now nationally on this group. And it can take many forms, such as requiring nursing homes to develop effective recruitment and retention strategies, ensuring adequate staffing and training. We have to examine wage structures, and many direct care workers have multiple jobs because their wages are kept so low and that they live in poverty that they themselves can't afford their own healthcare. as well as creating appropriate training programs and career pipelines. So that is our fourth recommendation. And for our fifth recommendation, I'm going to turn it over to you, Roseanne.
Well, thank you, Laura, and thank you everyone for staying with us until the end. I do want to say that our last recommendation really focused on strategies for implementing COVID-19 testing and vaccine distribution. And as we started the report, COVID was an evolving concern, and it still is. But there's really, I think what we really shed light on is that, number one, we need to make sure that we can get the vaccines out there to our rural communities and to areas where we have pharmacy deserts across the state. And if we do have areas where there are pharmacy deserts, maybe we need to look at alternative strategies. The mass vaccination sites will not remain in existence forever. It costs too much money. But maybe we need to look at ambulatory care facilities like kidney dialysis centers or different types of structures so that older adults and everyone in Pennsylvania actually can get a vaccine when they are ready to be vaccinated. And that leads me to really shine a light on, this is really a teachable moment, because we don't know what the future will be. This is the first pandemic that we lived through. There may be more in the future. And we need to make sure that older adults have access to healthcare, have access to immunizations across the state. It's just not a COVID vaccine, an annual flu vaccine. There are pneumovax, there's shingles. I mean, there's so many vaccinations that older adults need to maintain their health. And if they're living in pharmacy deserts and don't have access to healthcare, this is a problem. We also need to really think about vaccine hesitancy and developing those culturally competent strategies so that we could develop and target messaging for different populations. There's not going to be a one-size-fits-all approach, and every community stakeholders need to work together so that we could target and message for their responsive and respective communities. So I'd like to stop there now and turn it back over to Angela.
Wow, thank you so much for joining me and sharing the actionable recommendations that we have put forward in the report. They're very important, and these are recommendations that are applicable. You can apply these. It's very clear from everything that we discussed in this hour that there's no one solution to address the various disparities mentioned today, and there's no one magic bullet. Rather, we are looking at a multi-pronged approach targeting multiple risks and structural determinants that are very necessary to have us have a greater understanding county by county of the differences in the aging experience. And that's very important that we want to take a look at this county by county, which up until now, there has not been much data that has pulled together county-specific data, so that is a very important factor. And we want to take this and we want to develop targeted policies and practices that address the unmet needs of the populations, especially our 50 plus. So with that, we wanted to thank our amazing team at Drexel University and our very committed stakeholders. And I want to say how difficult it was to comb through data and research in the midst of the early days of the pandemic, which is when we started this. So not only is it a labor of love and commitment, but we seriously look at these issues that not just affect, our state, but it affects our communities and where all of us live. And with that, I wanted to just take the last few minutes of our time together to pose some questions to our stakeholders and guests, if that's okay. And I hope that we still have Dr. Axius still joining us.
I'm here, Angela.
Great, Jean. Thanks so much for hanging in there with us. As you can hear some of the great data points that were shared in the report. You made a really great statement earlier of what is the cost of doing nothing. And I just wanted to talk a little bit more. Why now? Why is AARP looking at disparities across the country?
I think we have a tremendous opportunity, Angela, to really close the opportunity gaps across sectors and industries. I think that what we're seeing across the country is the fact that that these disparities are such that it's now there's a great sense of urgency, not just an urgency to solve these disparities, but there's also an economic implication if we don't solve these inequities. And those cost factors can be in many of the things that we talked about today. whether it's the emotional costs, the cost in terms of lost lives, the cost in terms of the lack of access, the cost in terms of really the inability for people to live a longer, healthier, more productive life. And what does that mean for our society more broadly? So I think now is the time. AARP is extremely involved and has always been involved. But we're seeing tremendous synergy and energy in the public sector. We're seeing that in the private sector. And I think that we really do have an opportunity to really think about the future that we want. And COVID, I would like to be clear, COVID-19 did not create these disparities. It's only amplified and exacerbated what has long been structural, long-standing issues. So as we really think about the opportunity to move forward, Angela, I think it's critically important that we are not timid in our responses. And as you indicated, this will require a multi-pronged, multi-sectorial approach, and that we have to be bold and courageous in solving these. These are solvable challenges, but we all have to do our part in helping to imagine that future that we want for not just ourselves, but for our families and for our neighbors.
Excellent points. Thank you so much, Dr. Axius, for the work that you're doing on behalf of AARP members and the 50 plus all across the country. And there will be definitely more to come. My next question is for David Saunders. Thank you so much for staying with us. We appreciate your commitment to this issue and the work that you lead across the state of Pennsylvania, looking at these various disparities. We talked a lot about geography in terms of disparities that exist here in Pennsylvania. Could you speak a little bit more to the racial disparities and how our communities of color are impacted across the state?
Well, as I alluded to in my discussion a little bit earlier, you have what you would expect, or what many people might conjure in their minds as it relates to the plight of urban Pennsylvanians, specifically those of African American descent, Latino populations. We're talking hundreds of years of disinvestment, many years of racist policies and practices. And due to those things, you have individuals that are dying in their early 60s as opposed to 75, 78. You have higher levels of heart disease, cancer, tobacco, obesity, you name it. And this is really endemic. It's not just Pennsylvania. I mean, this is across the country. So you have all of those things. Again, both for African Americans and Latinos. Some of that those same issues occur in our rural communities for our white Pennsylvanians, many of which are dealing with income issues, dealing with some of the access issues that Laura and Roseanne spoke to in regards to lack of access, lack of pharmacies, lack of primary care physicians. But so much of it is along the lines of either racial and ethnic or income. And I would agree with Jane that these are solvable problems, but you really have to get at the root of the issues. And you have to have those uncomfortable conversations. And since all this has now been highlighted, why not keep that light shined on the issues and really do something about it? And I think we're in a position to do so.
Thank you so much. I feel that we are as well. Let's keep this momentum going. We spent a great deal of time this morning speaking about the digital divide and the access to the internet that are not equal in various parts of the state. And Jeffrey, I want to pose this question to you in terms of what are the implications right now to our healthcare for not having equal representation for digital access?
Sure. Well, I think as we've learned, again, with the pandemic, as we talk across the Commonwealth with healthcare providers, we hear of stories of podiatrists saying that because, an individual did not have the same access to technology, just to simply more accurately look at a foot. We're hearing of situations where we're seeing amputations that have had to increase. We've heard of stories with individuals with diabetes where diabetes management, which we know is a complex situation. But again, if we had access to equitable technology, during a pandemic, maybe some of those more severe diabetic management cases could have been handled more effectively. And the issue goes on. We've also heard of cardiac issues. I'm not talking about emergent ones, but ones that, again, if we had equitable access, hopefully we could have better managed them. The one thing, Angela, that I do want to mention that I do know Laura had spoken to a little bit, and Roseanne did too, is when we look at the vaccines, this is similar. And I just want to applaud AARP and applaud the Pennsylvania Department of Health, because both entities have been very involved to ensure that our Commonwealth has equitable access to vaccines. And I know we have more work to do, but we have mobile clinics that are traveling the Commonwealth. We have community neighborhood type of approaches, and we're one of the states that actually is doing better than some others. And so yeah, we have work to do, but let me just remind our policymakers that all of them do it too. Both parties. This isn't a Democratic or Republican issue. This is a Pennsylvania issue. And I think this report highlighted that it is the responsibility of all to get out there, fix this infrastructure issue of digital divide, as well as fix this public health opportunity for us to vaccinate everyone. It's education, but it's also our opportunity to save lives. And I just want to call on all of them to help us do that.
Absolutely. We definitely want to seize this moment in time, looking at lots of lessons learned and how we can move forward collectively with funding, resources, and more data. At this time, I just wanted to, again, thank everyone for joining us, for looking at some of these serious issues that have been exacerbated for COVID-19, as we discussed, but some that we do have some now tried and true actionable recommendations to move forward. We look forward to collaborating not only with our stakeholders, but many of you that have taken time to join us. We are available to answer any further questions that the press may have. And also, we look forward to working with our elected officials and our policymakers to really look at how we begin to solve many of these disparities in the state of Pennsylvania. With that, I thank everyone for their time. If you have not had a chance to find the report, I encourage you to do so. You can find it on AARP Pennsylvania's website, and that's aarp.org/Pennsylvania. Thank you all so much for your time this morning, and have a great rest of your day.
Thank you, Angela.
Thank you.